So thank you. I think this is the last time you're going to have to tolerate me, so that's good. Thank you. Maybe at dinner you have to tolerate me some more, but we'll have a cerveza in our hands, so it'll be much better. The last thing I want to do is go through all the slides you've already seen twice yesterday. So I want to share some perspective. I think conversation might, I haven't talked to any new pharmaceutical companies in the last hour. I want to try to keep it simple. I've been thinking about this topic here. I know many of you, you're very good doctors, and you worry about your patients. But it's not your fault. It's not your fault. So you have to sort of understand that, let's say, after 3 cycles of chemotherapy, if there's still a lot of cancer there, it's not your fault. It's bad biology. And guess what? 2 extra doses of chemotherapy is not going to change the biology. So we argue about, should we do surgery? How do we do it? Do the best you can. I want you to continue to be compassionate, to care for your patients. I want you to care. But in that patient, let me tell you how to do a debulking. Whether you're a surgeon or not, you do this. Whoop. Put a retractor in. Whoop. And then there's the omentum. And we have instruments, electrocautery, it's like scissors on a paper. Whoop, 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 whoop. Greater omentum. Literally. And then you make an incision over the psoas. And you go this way, because lateral is the blood vessels. You go this way, and you find the ureter. Okay, make a little incision. Whoop. Okay, both sides. And then you take the bladder down. It's easy. You just pick it up and whoop, whoop, whoop. And then you take the top of the uterus off. You don't need to take the cervix. As long as the cervix is normal, leave it alone. You got emails to check. And if there's all that stuff on the diaphragm and all of this, not your fault. Close her up. Do the enhanced recovery, and she'll go home in 2 days. But if she's a good responder, if you want to do it with the laparoscope, go ahead. Who cares? You see, we have to make it simple. We have to make it simple. And I feel badly that not every patient responds well to frontline neoadjuvant chemotherapy, but it's not your fault. The surgery is still important. If you don't get that omentum out, you don't get the ovaries out, you're just going to pay for it later, okay? So this is important. We live in a biomarker-informed world. We all like biomarkers. And we used to use histology, and you get that. And you can have these slides, as I always say. But it's really the molecular signature, right? And someone asked me, I was debating, Katie Moore and I are very good friends. She's a genius. And we were debating, and she's always trying to challenge me. I like to be challenged. She comes up and she says, Monk, what's the most important biomarker for PARP inhibitors in high-grade serous ovarian cancer? She was testing me. BRCA, HRD. I said, chemosensitivity. She said, rats. You're right. Because when the patient is responsive to chemotherapy, the way platinum works, it causes platinum adducts, breaks the double-stranded DNA, and ultimately the cell dies. That same process is how PARP inhibitors work. So PARP inhibitors are important. You can do a biomarker. I just talked to some of my friends here. I guess the sponsor will pay for HRD testing. So if it's free to the patient, order it, that's fine. But the most important biomarker is platinum sensitivity. So when I see a patient, she walks in the room and she has all these clinical characteristics. Molecular care, histology, and I can't fix it, and it's not my fault, okay? And I try to be positive, And then ultimately, we have her comorbidities. She may be frail. And then ultimately, the only thing that I can change is that. I can change the treatment. And ultimately, I have to look at accessibility. I've heard that several of these agents are approved in your country. God bless you. They're not approved and reimbursed in every country. I was talking to Alicia, and I'm Brad, and she's telling me that the pharmacies are not always perfect, that maybe the sponsor will pay for HRD. Maybe you say, oh, I want to give a PARP inhibitor, but getting the medication is challenging. And I was thinking, well, that's probably not just for PARP inhibitors, that's for other medications. That's a local thing in your hospital. So I think I have to understand that. I heard that this is still common. I heard that as many as a third, maybe 40% of patients in Colombia get no maintenance. In where I work, if you would do that, you would be disgraced. Just saying. There are things that we don't believe in the U.S., like shooting people, if you read the news. And if you shoot someone, you're going to be disrespected. So this is, and the reason, because it hurts people. And I don't mean to be dramatic, but if you shoot someone with a gun or you don't give them maintenance therapy, they might die. I get it that everyone's going to die anyways, and I know I'm over dramatic here. But maintenance is important, and the way you get to maintenance is to stabilize the patient. Neoadjuvant chemotherapy generally, interval debulking surgery, 3 or more cycles of chemotherapy, and then you put them on maintenance. And I'm not going to sit and argue or debate which maintenance you should use. That's a personal decision, and we'll get into this here. But we have to improve PFS and over. We have to. And we have to minimize toxicity. And I'm going to talk a little bit about all the PARP inhibitors, but think about what niraparib is. You're just asking her to take a pill a day. I mean, really? It's paid for by the insurance. And I'll talk about how to control the side effects. And if you look at the quality of life, the patients that take niraparib or other PARP inhibitors do better than if you don't. Okay? So that's what we're trying to do. I showed this is one of my favorite slides. I've been working on this for a long time. We're going to continue to iterate. Let's see what else I got here. I want to talk a little bit about bevacizumab. Bevacizumab is very important. Again, whether you use bevacizumab in the front line or in recurrence, that's up to you. You probably can't give niraparib bevacizumab in the HRD. That's fine. If you want to use bevacizumab olaparib in HRD, that's also fine. This is a very important medication. I've been involved in this for many years. I was the first one in the world, not I, we, in 2005 to show that bevacizumab worked as a single agent. We had it approved in colon cancer, and so we gave it to a patient after 11 lines of treatment, and her CA-125 fell out of the sky. You know what really happened to this patient in the end? And I'd made several mistakes. She was doing great, and she got kidney disease. She got proteinuria. I've said many silly things in my life. And I said, well, that doesn't matter. I mean, what's the worst thing that could happen? Go on dialysis? She said, dialysis? Oh, I don't want to go on dialysis. She stopped her bevacizumab, and she died in 6 weeks. So how we communicate is important, but this is a great medication, and you're familiar with the story. You know, we did single-arm studies. Berger, we were fellows together and worked together for many years. Stan Kay, who we know very well in the editorial now, 19 years ago, say this may be the finest moment for bevacizumab. And I would have a tendency to agree with that. And so we added bevacizumab, as you know, to carboplatin and paclitaxel. There's been this ICON 8B. I'm not going to get into it about weekly. I think it probably is a difficult treatment regimen to follow. I think most of us give every 3 weeks, as the initial ICON 8 showed. And we added bevacizumab to it. Ultimately with chemotherapy and in maintenance, and also ultimately with chemotherapy alone. We did it for 15 months because we figured out that was the median time to progression. We wanted to cover half of the patients. I think in PALA-1 they get it for 2 years. I don't have any problem with that. But as you know from the BOOST trial, longer is not better. A lot of people quote the data in the paper. The data in the New England Journal paper of ours shows that there were CA-125 progressions. This is the indication for bevacizumab, 6.2 months. It's not the 4 months and change in the paper because we censored the CA-125. There is no difference in survival. I don't think it's possible to show overall survival in the front line. Even SOLO-1, which is a wonderful study, even to this day, doesn't show overall survival from a statistical standpoint. And certainly PALA-1 also doesn't, and I talked about that yesterday. What's important is that we control the tumor, we delay the next line of therapy, we maintain quality of life, and that's called progression-free survival. So bevacizumab is important, and I never want any of you to think that I'm an advocate for PARP alone only. Is PARP alone an option? Yes. And you're familiar with my work with Athena Mono and Rucaparib. It is an important treatment. I don't know the right duration, but I think 15 probably. It can be used again and again. I used the term yesterday that it's a promiscuous medication. I know we like biomarkers, it doesn't have one. I get it that 6.2 months at the median and a hazard ratio of 0.62 isn't enough. We really have to respect the bevacizumab contraindications, and there are lots of them. Uncontrolled hypertension, bowel obstruction, history of bowel perforation or inflammation of the bowel. So that's that. It really is these Nobel Prize winners 2015. I told you that the winners in 2015 also were for T-cell immunity. That was medicine. This is chemistry. It's pretty cool. Same year. And so here we are with DNA repair. Now again, double-stranded DNA breaks, that is to say, chemotherapy sensitivity is the real biomarker. And you guys know that what PARP does, poly-ADP ribose polymerase, it's an inhibitor of single-stranded DNA breaks. And if you inhibit single-stranded breaks, they become a double-stranded break. And if you fix them, they're normal. But if you can't fix a double-stranded DNA break, then ultimately the cell dies. And homologous recombination is repair of a double-stranded break using the sister chromatid as a template. So that's called synthetic lethality, where you have to have both alterations. You have to have a single-stranded break and a double and an HRD to be lethal. Either one, the cell survives. I like it. It makes me very happy that that this test is available to you for free in your patients. Professor Ray Kucard said yesterday that you can use any HRD score as long as it's validated. It's very easy to validate. And really what this is, and then my choice has 3 tests: loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions. But it's really LOH. And LOH is easy to calculate. It doesn't really take much to validate it. I told you that you can get NGS on your dog to find out what kind of puppy you have. You can get NGS also on your tumors, relatively inexpensive. But the good news is that you can get it on your patients if you want. Now, niraparib is indicated for all comers. Platinum sensitivity, I already said it's probably even a better biomarker. But if you want it, you can get it. I can only give PARP inhibitors in HRD in the US. In Europe, they can give it in the all-comer population. So again, it's also a prognostic and predictive biomarker. Here, if you have HRD low, you live shorter than if you're HRD positive. So there are many validated HRD tests, and that's just fine. And I do HRD in every patient, and it can be paid for by insurance. So we have a great relationship with NGOT. These are all NGOT trials except PALA-1, collaborative trials, GOG NGOT. PALA-1 was only in NGOT because bevacizumab was approved in 2011, and we didn't get it till 2018. There were 7 years. It was the standard of care in France, and that's why the PI of PALA-1 is French. But it's a purely European study. It's an often misunderstood study because it wasn't an investigator-initiated trial. It wasn't run by the sponsor. It's an important study, and we've come a long way. And this is busy, and I don't intend for you to read it. It's to remind me to teach you one thing. PARP inhibitors are not the same. You heard Professor LaRusso here just talk that dostarlimab and pembrolizumab and endometrial, it probably doesn't matter. Here it matters. The doses are different, the metabolisms are different, the side effects are different, the schedules are different, the indications are different. So that's really, really important. And someone asked me, Monk, what's the biggest difference among them? And the biggest difference is the schedule. Niraparib is once daily. And the reason that that's important to me is because I have my patient take it at night with a small meal. I get the sense that the gastrointestinal toxicity, the nausea, if you will, is from irritation from the upper GI. It's not the chemotactic trigger zone. So if you can clear the medication out of the intestine while she's asleep, you have less nausea. You can also give an antiemetic at night. Many of them are sedating. Well, that's why you go to sleep anyways, because you want to go to sleep. So if you give a little olanzapine with a niraparib at night in a small meal, there's an opportunity there. This further emphasizes the fact that they're different medications. For example, LFT is more, I don't have it up here, LFT is in rucaparib. Hypertension is in niraparib. It's an inhibitor of catecholamine reuptake. Pneumonitis is actually an adverse event, and so on. So I think this exact slide was shown by Professor Ray Coukard. Cross-trial comparisons are inappropriate, and I really don't want to get into that. So I don't really want to go through all the slides from the studies. You know them. Solo 1, it was 3004, it was the 4th trial that we did. Katie Moore was a young, she's still young, she was a very young investigator, now she's just young. And she was our lead investigator, and I'm not gonna go through this, it's in the deck. I do wanna say that we took a risk on Prima. Antonio Gonzalez Martin is the NGOT PI, we took a risk. The intention was to expand the opportunity for PARP inhibitors. We were certain, we're not always right though, that it was going to work in HRD. So what we did is we powered it, which would be twice as many patients as BRCA. So it was powered, if it was positive in HRD, then we would carry the alpha forward in the all-comer population. And we did it. You did it. We enrolled a high-risk population, a lot of stage 4s, a lot of neoadjuvant, a lot of residual disease, and so on. We don't talk enough about this, hardly at all. It's really important. Patients had to either have normalization of their CA-125 after frontline carboplatin paclitaxel or decreased by more than 90%. Why would we do that? Why would we do that? Because we wanted to enrich the population. And if you look at PALA 1 did not show a result in non-HRD. This did. And the reason is not because olaparib is not as good as niraparib. It's not because of the bevacizumab in PALA 1 that it's negative and HRD test negative. It's because they didn't enrich for platinum sensitivity. That's a really important aha moment. It works in HRD. This doubling of the PFS, and that's why I'm so passionate about it, is important. The all-comer population, I get it, a lot of it is drawn by the HRD, but we have long-term follow-up here, 6.2 years. The HRD test negative is here on the side. Some people call it HR proficient. I prefer HRD test negative because we don't test for proficiency, we test for deficiency, and if it's not there, then it's negative. So the hazard ratio here, 0.65, that's still a big number. And the reason the delta, that median is so small, is because it was a high-risk population. If you take a more favorable population and get a 0.65 out of it, then ultimately you would get a different delta. The overall survival, I had the privilege of being the first author last September in Annals, is probably what knocked out the HRD test negative indication in the US. I don't really know how you can say there's a decrement here in survival. Look at this hazard ratio, 0.84 to 1.23, and I get it that HRD, but if you look at the hazard ratio in the HRD test negative, it's 0.93. We're not hurting anybody. And that's why you have it in your country. That's why Europe has an indication in the HRD test negative. And if you want to, and so, well, then why did the FDA say what they did? And I asked them that in the Journal of Clinical Oncology in a letter to the editor in December. And they basically said, we can do whatever the heck we want. Okay. They're very proud, the US FDA, that every PARP indication, every one, and there are 3 of them in prostate, is biomarker informed. And so that, I want to give you the power. I want you to give the decision-making process with your patient rather than to have it be made by the US FDA. And the reason that OS is difficult to interpret, because there are several factors that we don't control for. They live for a long time. They get 5, 6, 7 treatments. They get mirvetuximab in some. They get reoperated on. They get all sorts of things. And then they cross over to PARP. So I don't know how you're supposed to interpret overall survival. And when we were here with Isabel Ray-Cocard, I sort of challenged her. She says, I can't wait to see the Athena overall survival. I'm like, why? I know what it's going to show. And I also know it's going to be uninterpretable. So that's the point. And this is the crossover, and you could see that the difference in crossover varies depending on what you're getting. In the HRD BRCA, the crossover is almost 58%. So, and it wasn't just PARP, there was also crossover to many other medications. This is a monk slide. When should exploratory endpoints guide clinical practice? I don't know. I realize that you want to know what's best for your patient, and you want to individualize and personalize. And I get it that clinical scenarios don't always fit exactly in the study, but and you heard about the Siendo, selinexor. We really didn't mean to use those to guide treatment. We share those to figure out what the next trial we should do. So they're hypothesis generating, not hypothesis testing. And you're familiar with the clinical outcomes, but it's the patient that matters, the quality of life. We want them to live longer and live better. So monitoring matters. So as you know, we started in the 300 milligram all-comer. We individualized it based on the weight, really. I get it that the platelet count is in there, but if the platelet count isn't over 150, then delay a week or two before you start maintenance treatment, and it'll get there. So this is really weight-based. CBC weekly during the first month. I do it for every PARP inhibitor, not just niraparib. Weekly labs. I do CA-125 every 3 months. I also do CT scans every 3 months. You've heard, and Professor Ray Coquard said it, that CA-125 isn't good enough. Blood pressure, also for niraparib, and that's important. Again, I like PALA-1. I like PALA-1 a lot. I would never say that it's an inferior PARP inhibitor. I would say that it's given twice daily because it's true. But this is not enriched for platinum sensitivity the way Prima is. So that really is important. The study was, you can't start dividing it up into subgroups. And the FDA has been very defensive about it. I think there was a halo effect, meaning what happened for Prima and what happened for PALA-1. They got FDA approval 3 weeks, within 3 weeks of each other. So it's a good treatment. I'm going to skip over this. Athena is out there. Rucaparib, the advantage of rucaparib is the dosing flexibility. It's 600, 500, 400, 300. When you start niraparib at 200, you got one dose, 100. So I like the dosing flexibility. Again, this is approved in Europe. It's used in several settings. It was designed the same way as Prima. I wonder why. Well, it's the same guy. And why did I do it? It's a good question. I think it takes 2 studies to convince people of things. So the idea is sort of like in the ICON 7 GOG 218 was to the BEAT CC, the Keynote 826. There's several examples where we can add confidence. But this is, again, more than doubling the hazard ratio in the HRD, more than doubling the hazard ratio in the all-comer. And again, this just proves the point that PARP inhibitors are important in maintenance. And here, very similar, 0.65 in the non-HRD, and they call it LOH. It's the same thing. Let's see what else we got. So I think you guys get it. Testing is really, really important. Germline, as well as somatic. Neoadjuvant chemotherapy, I agree with what was said. If you have to give it a second thought, that probably is a neoadjuvant patient. I agree that CAT scans are very informative. Giving bevacizumab is interesting. It doubles the cost. We don't have a PARP alone arm in PALA-1. If you want to give PALA-1, that's fine. If you want to give bevacizumab in the HRD test negative, that's fine. If you want to give niraparib, that's fine. I used to be more of a bevacizumab person, and then COVID happened. So we stopped giving bevacizumab in the HRD negative because fusion centers were complicated, and we never went back. So we now use niraparib in the HRD test negative for the preferred until last June when it went away. So now we're back to bevacizumab. And if you know anything about me, if I don't like it, I'm going to try to defeat it with a clinical trial. So you'll see a lot of settings here with bevacizumab plus an ADC. I think there are 8 studies in development. So non-HRD, get your bevacizumab in the maintenance phase, get your TROP2, your CDH6, your B7H4, your folate receptor alpha, and so on. So these are coming. We're going to need your help in Colombia to get those done. 7 or 8 studies in flight. So that's all I have. We have 30 minutes for questions. I asked Alicia to challenge us And I want to open it up for questions, and thank you so much for having me.
Thank you so much. So thank you so much, Dr. Monk, for an excellent talk. So I want to open, podemos abrir los micrófonos si tienen alguna pregunta. We translate. Vamos a traducir si necesitan traducción o pueden hacerla en inglés. So I want to start with a clinical case. So I have this really young patient, 54 years old.
Thank you. 54 is very young. Go ahead.
So she has a stage 4 ovarian cancer, a high-grade serous ovarian cancer. She has a pleural effusion and mediastinal lymph nodes. So up front, I go with bevacizumab, carboplatin, and Taxol. So because of this stage 4 and
Yes.
wet disease, and then we test germline testing, and that resulted negative. And she also get a myriad testing, somatic testing, and she also turned out negative. So, negative.
Dang
So,
it. Dang it. Okay.
So that's the point. So after 6 cycles, the serum tumor marker was still positive. At the beginning, she was almost 6,000, and now she has 200, but a partial response. Well, the question is, we decided already to go on bevacizumab. The first question will be, what is the optimal dosing? Do you use 7.5 or 15? And the second question will be, do you think we still got evidence from phase 2 trials, the ovarian trial, that combines niraparib with bevacizumab? Do you think that we have all comers approval? Do you think it's feasible? Do you use it? We have this very young risk patient.
So I don't know you very well, but I'm starting to like you a lot. Because that's a hard question. So think of it. After 6 doses of carboplatin bevacizumab, I hope she had surgery, I hope so. And you stop the bevacizumab before the surgery, generally at cycle 2. Give cycle 3 without bev, do surgery on cycle 4. Do surgery and then no bev on cycle 4, so that she skips 2 doses. So the oncologic principle is don't give up on stop the treatment if it's working. So that applies here, and so I like that. On the other hand, it's not working enough, and you're going to lose the opportunity to give her a PARP inhibitor, because you probably can't give her a PARP inhibitor. Can you give a Nova? Is Nova or yes or no? So he says yes, second line is approved. That makes it easier. Nova is not approved in my country. So I think that's a fairly straightforward. Let's keep the bevacizumab going. Let's get as much mileage as we can. She'll probably have a platinum-sensitive relapse. You can give her a platinum doublet again, and then I'd give her Nova next time. So adding a PARP now to the non-HRD patient with bevacizumab, I would not do that. I think there's very limited evidence there. Again, I want patients to live longer and live better. Sequencing is challenging, but I can create a path here where that patient is going to get chemotherapy probably twice, going to get bevacizumab once, and going to get PARP inhibitor once. And then by then, you'll have mirvetuximab approved, if you don't already.
Next year.
Let's go. And she's going to be alive next year. In fact, this patient, think of it. So she got 5 months of carboplatin paclitaxel. She's going to get another year or so of bev. Now she's going to be 18 months into this. And then you're going to give her carboplatin and paclitaxel another. Now she's 2 years. And now you're going to give her niraparib as per the NOVA trial. And then she's going to get a year out. Now it's just 4 years. And she's only had 2 lines of chemotherapy. And she was stage 4. So this is how we do it, okay?
So the patient had like a complication. You didn't answer the question about
okay.
the dosing.
So let me go.
But I'm gonna end up what happened to the patient.
Let me finish and answer the question. I want to hear about it. So the starting dose basically should always be 15. I know Icon 7. Icon 7 is a study that you can't really interpret. But and I get it that we don't teach people to dose reduce, but we do. So we dose reduce for some of the non-hematologic adverse events, and this is after working on bevacizumab for 20 years. The most common reason to dose reduce is the dysphonia, the hoarse voice, is the lacrimal congestion. These are very well documented adverse events of bevacizumab. Even the hypertension, I don't generally do dose reduction for hypertension because I have antihypertensives. I do dose reduce for proteinuria. Let's say the proteinuria is getting up to a gram and a half. It's coming, and sometimes by dose reducing, I can have those off lacrimal, voice box, kidney. So let's tell me what happened.
So the patient had a bowel obstruction. So
How? But her cancer had gone away. How'd she have a bowel obstruction?
Well, first we got a consultation with the surgeon team, with the gynecologist.
But how did she get a bowel obstruction? Was her cancer progressing, or?
Yes.
So she had progression.
So after the bowel obstruction, the surgical team didn't agree on surgery. That's a problem that we were just talking about. So
what kind of bowel obstruction?
So it was like a really easy one. Like
what?
Easy.
There's nothing easy. I've had.
So
where was it?
We gave him some steroid therapy.
But where was the bowel obstruction? In the sigmoid, transverse colon, small bowel?
Small bowel.
So if it's in the proximal small bowel, it becomes a big problem. The good news is, in the proximal small bowel, it's easy to put back together. And
So,
if it's in the distal colon, then you can pull up a colostomy. But for a general surgeon to do a sometimes called a small bowel resection, Kinderspiel. Do you know what Kinderspiel means? Kinderspiel is German, which means child's play. So
I didn't convince the surgeon to operate at first, but
let's
with this bowel.
Let's keep talking.
But
How many surgeons are there in Colombia?
A lot.
So just get a different surgeon.
Yeah, I told her to get a second opinion.
No, you don't tell her to get a second opinion. You make an appointment for her and say, I'm going to ask you to see this doctor.
But the good news with the bowel obstruction, that was like, I get the operation, and the patient, now is progressing and is also making a kidney obstruction. So
let's keep talking. So first of all, people get constipated. And so when that patient is admitted with a bowel obstruction, the first thing you do is you start some enemas, cleaning it out. And several times you clean that out, and that partial bowel obstruction will resolve. Yeah. That's plan A. That works at least half of the time, and that's not always cancer progression because the bowel is kinked and narrowed, so that's important. Ultimately, if it is a complete bowel obstruction, then she needs surgery and because it's progression, and then immediately after that, literally just like a primary debulking, when you do a primary debulking, you have 3 weeks to get the patient on chemotherapy. Otherwise, the cancer grows back. So you have 3 weeks. So what we do, after a primary debulking or fix this bowel obstruction, I see her at 2 weeks. This is what we did. This is what we're going to do. I give you a week to get ready. I'll see you in the infusion center. 3 weeks. Okay?
Well,
and then ultimately she'll respond, and then she goes to Nova. Keep going. And I know it's not a perfect world. I get it.
So she actually had a partial obstruction because we put him on steroid therapy and a laxative, and she resolved.
There you go.
And next week, the patient got back into the hospital and get the bulking surgery. And
Oh, this is for the bulking. I thought this was after the 6 cycles. Okay.
no, because it was
I
in
got
the
you.
meanwhile.
I got you.
So
It's fine. Good.
I'm fearless.
Fearless. Go.
I,
Let's go.
I only gave her 5 days to recover after
It's okay.
the surgery.
All right.
So I'm still waiting, pending on the foundation results, and I'm also testing the folate receptor alpha.
Be good to have that in your pocket when it gets approved.
Yeah.
I love it.
So
But this, and I always say the most important factor when you get a serious illness, which could be you need your knee fixed, picking your doctor. Because you'll do what your doctor says. So the best thing that could ever happen to her, the patient, was picking you. And you think about it. You're ruminating, oh, I'm discussing it in front of 50 people. It's great. And so keep it up. Be fearless.
thank you. So Abraham, ¿tienes una pregunta?
Yes, doctor. A very nice case. Hope she gets well. Doctor, when you face the progression to the EPARP to niraparib, for example, during the niraparib, if the progression is a small one, because I have a clinical case, a BRC1 young patient, 40 years, she present the progression as lymph node, two retroperitoneal lymph nodes, and we get her to the secondary cytoreduction.
Secondary cytoreduction.
Cytoreduction.
How about primary radiation?
We discuss all that. The staff decide. I don't remember why okay, no, because they balance with that we are offering based on nothing that we can cure more with the proper surgery than with radiotherapy. So after the resection, I decide, that was me, not the tumor board, I decide to re-expose her to platinum adjuvant cycle.
Sure.
And now I don't know if I should restart PARP inhibitor or not, or
So there's no right answer, and I love these questions. The easy questions are easy, but these are, real life is not easy. So let's go back to the decision to do radiation or not. So radiation can effectively cure something about like that in 5 days. Almost every patient with ovarian cancer of mine gets radiation at some point. Almost never do they get operated on twice. And the reason is because I do all these CAT scans, and when they have this, I hit it. Actually, the radiation doctor hits it. And she doesn't even have to miss work. But the surgery can be all sorts of problems. So the radiation is and then what I would do with that patient after I stop the PARP inhibitor, because PARP and radiation generally cannot be given together. So several instances, I'd stop the PARP inhibitor, hit those oligometastatic lesions in a week, SBIRT, wait a week, and put her back on the PARP, because those clones are resistant. Now that translates very well into your plan, right? Is that you've eliminated this surgically. It's okay. The surgery's too hard. It's too hard on me. It takes time. It's hard on the patient. It hurts. So, but if radiation, not always, but for small things, okay? And less than 5, 3 no-brainer, 3 to 5 questionable. Then you can, because you've removed the clones, retreatment with PARP is a good idea. It's not sort of the Ovario trial typically, and you're a smart guy, I know you pretty well. That's why you're bringing it up, because it is PARP after PARP, but you've removed those resistant clones. If you wanted to be more strategic, you could do liquid DNA and see if she has because you said she's BRCA. you could see if she has a reversion BRCA mutation. And if she has a reversion BRCA mutation, I would not retreat her with PARP. That would add more confidence to the idea of giving her PARP after. That's a very real world thing. See, this is now twice. Gynecologic oncology, I do surgery less and less, but for years, surgery and chemotherapy both. So I don't have to argue with the surgeon because I'm the surgeon. And I promise you, when it comes to radiation, if I send the radiation, a patient to you as a radiation doctor, and you don't do it, it will be the last patient that you get. Okay, and so, and I know now I know whether I don't need that guy to tell me whether radiation is indicated or not. I just want him to do his job. And if he disagrees with me, he can call me and we can not argue, not fight, but discuss. But I can't remember the last time I referred a patient for radiation and the patient didn't get radiated. There are just too many radiation doctors out there.
I now remember something that I want to ask you. In the MDT, someone argued that how can we know that she doesn't have another disease or more disease different that we saw on the PET CT scanner?
So I'm a good person to argue with. So I would say, of course she has disease. Duh. I didn't say she didn't. Why would you say that? So thank you. I'm glad we agree. Now you build consensus, okay? And then you say, that's why I'm going to continue her on her PARP inhibitor, because we've already shown and proven that it's effective in controlling all the cancer in her body except for those few spots. Any other questions?
We have another question.
I have other clinical case. It's not a first-line one, but I would like
Thank you.
to ask you.
Thank you.
She's a 62-year-old patient. She
Still
was
young. Keep going.
Yeah, she was first diagnosed with a high-grade serous cancer from the ovary, and she started in other center with the primary cytoreduction, and then she got the adjuvant chemotherapy with carboplatin and paclitaxel, but she didn't get the NGS for BRCA mutations, and she, because of administrative issues, she could not get the my choice. So
Was she completely resected?
yeah,
Okay.
and she got 6 cycles
That's
with
right. So
carboplatin paclitaxel.
There is an argument out there that in the completely resected primary debulking, that maybe that patient should not get bevacizumab. I'm fine with that. Many people would do bevacizumab, particularly if there was upper abdominal disease, because the risk of recurrence is high. But keep going, 6 doses.
And
Primary.
she lost follow-up with her physician. Then she arrived to us with a peritoneal disease.
Yep. How long? How much time between?
1 year and a half.
Which is like the average, right? Because the time to progression is due to biology, treatment, and also the tumor characteristics. And so she started from nothing, as opposed to starting from something. So if she started with something, the time to progression on average would be 10-ish months, but she grew from nothing, complete resection. So you're right in there, 18 months is good. She's been alive for 2 years.
So we re-exposed her to the carboplatin paclitaxel.
Okay.
She had a not so great
With Bev this
experience
time.
with the surgery, and we talked with the surgeon. And
What surgery?
with the first cytoreductive surgery, she has not a great experience. So we proposed her, after starting the chemotherapy with a great biochemical and immunological response, to reoperate her.
Why? So secondary cytoreduction is a very controversial thing. And as you showed from GOG 218, if you add bevacizumab to it, there's no benefit. So just give her, Oceans, or just give her carboplatin paclitaxel bev, or.
And she did it well with the carboplatin paclitaxel.
But why not bev?
We got an NGS information.
No, I understand, but why not bev? For second line.
Yeah, We started with bevacizumab.
Okay, there you
of
go.
course.
And so then, then the
Sorry.
next question, so why do a second operation on her?
She had a great response with just minimal disease that could be resected.
It's not, it's a discussion.
Yeah.
That's not a good reason. So again, if you don't like that thing, radiate it. I mean, this idea of all of the, and then when a patient has a bowel obstruction, she can't find a surgeon. So the secondary surgery is a very controversial situation. The patient that is eligible for secondary cytoreduction, in my opinion, in the US, is almost never. HIPEC is almost never. It's this, what this guy said, this handsome gentleman. He said, well, she's got systemic disease. Oh, let's give her a regional therapy. So she needs systemic treatment. So give her Bev. You're going to keep telling the story, and I'm sorry for interrupting. Give her Bev, then give her platinum again, and then you're going to give her PARP. And she's going to live for 4 more years, unless you have a surgical complication. So go ahead, you did your second
but we
operation.
got the NGS results with an ATM pathogenic mutation,
Okay.
not a BRCA1.
What was her HRD on that NGS?
The problem is a germline mutation. It's not a myriad choice.
It
It's
doesn't matter. What on the NGS, what was her HRD?
I'm not sure. But
when
I
you-
just got information about the ATM mutation.
So Isabel, I'm sorry to keep interrupting. Isabel Ray Cucard, that we don't look at the mutations for PARP. And she's going to get PARP anyways, because platinum sensitivity is the better marker. So she's going to get chemotherapy, Bev, second line, and then she's going to get platinum again with the biomarker that matters, platinum sensitivity, and then you're going to give her PARP. So now she's going to have platinum 3 times, surgery twice, Bev and PARP, and she's going to live for 5 years. So NGS to direct treatment in the recurrent setting, even HRD, just is not helpful. It's the paradigm. Platinum sensitivity is the best marker for PARP. Bevacizumab is important. You gave it first line. You gave it second line. Thank you. And then platinum sensitivity, and you get Nova. It's really cool. It's a good discussion. I appreciate the courage for bringing it up.
Thank you very much.
But let's defeat the surgery after secondary cytoreduction is so rare and unnecessary, and then the desktop trial. So the desktop trial showed a PFS benefit, but they cut the cancer out. When you cut the target lesion out, and I asked that question at ASCO when it was presented, it contaminates the interpretation of PFS. Because again, you have different starting points. You have cancer, and then you have no cancer. Where's the difference in PFS? Well, of course, where you start with no cancer. They progress at different times. But again, we have to go back to the paradigm. Chemotherapy, primary debulking or interval debulking, bevacizumab, PARP, platinum sensitivity, germline testing so that the sister doesn't get cancer. It's a good discussion, so much fun.
So last question. You mentioned earlier ctDNA. So do you think, I think you use it for testing to mutation resistance, but I was wondering if you use it to stop earlier treatment. Do you think it's possible to do let's say 1 year? Meanwhile, we're still pending on the results of the trials.
Yes. So ctDNA is also expensive. The companies would like you to do it every 6 weeks. They'd like you to do it every day, but let's do it every 3 months. It's valuable. And you do ctDNA for 2 reasons. 2 reasons. We talked about it for biomarkers, BRCA reversion mutations. You also do it for MRD, minimal residual disease. So you could do for MRD, and it's a piece of the puzzle. Yes. So if I have a patient on a PARP inhibitor for some time, 2 years, even though it's niraparib, and she's HRD negative and CA125 negative, I'm not very motivated to keep it going. So it is paid for by my government, and so we use it a lot. Again, there's two reasons to use it. Biomarkers, so in lung, I don't know if you treat lung cancer, you'll do ctDNA and you'll get the MET, the ROS, all of the things, the EGF, and so on. You still have to test the tumor for PD-L1, but ctDNA is two reasons. It's exciting. And cervical cancer, same thing. If you have a cervical cancer, you heard this at ASCO. If you have a cervical cancer and the patient is ctDNA negative at, let's say, we did 3 months, but at 6, that patient's going to be cured. Not every time, but almost every time. But if you have ctDNA positive at 6 months, even though there's nothing on her CAT scan, she is in trouble. So it gives you a lot of interesting information. It's expensive. It's getting cheaper.
I also use it.
Let's go. I told you I liked her.
So thank you very much, Dr. Monk. We learned a lot. I give it an applause.